The objective of the Decontamination Theory and Practice course is to provide you with a general overview of topics associated with the decontamination process. In this course, the spectrum of decontamination methods will be explored, along with guidance on choosing the appropriate process based on patient presentation. In addition, information on identifying locations for conducting the procedure, as well as advantages and disadvantages of the various decontamination systems available, will also be explored. Finally, you will acquire an appreciation for the differences in managing small numbers of contaminated victims versus mass casualties from a large-scale chemical release. Decontamination is any process, method, or action that leads to the reduction or removal of a hazardous substance in order to lessen or prevent adverse health effects. The procedure's primary objective is timely removal of the offending agent by the best means available. It should be performed whenever a person is known or suspected of being contaminated. A person is considered contaminated if they have had direct physical contact with a hazardous substance and if the agent remains on their body, hair, or clothing. Contaminated persons have the potential of spreading this agent to others. This is in contrast to a simple exposure, which means a victim has been in contact with a hazardous substance, such as inhaling a toxic vapor, but cannot spread this material to others. Patients who have vomited after ingesting toxic substances can also be a threat of cross-contamination or exposure to the hospital staff. These patients may require isolation, and continued use of some type of personal protective equipment may be necessary. The overall purpose for conducting decontamination is to prevent or limit the spread of harmful substances to you, your coworkers, patients, and the hospital. The process of decontamination should be viewed as a series of non-linear activities that range from scene evacuation and clothing removal to soap and water showering. Each step is designed to quickly limit a patient's exposure and potential toxicity that follows from contamination. Although an essential procedure, the actual act of performing decontamination should not delay other life-saving interventions so long as the caregiver is appropriately protected. Coming into direct contact with aerosols, solids, or liquids from a hazardous substance release will contaminate an individual. Limiting the spread of contamination at the hospital is best accomplished by following the R.A.I.N acronym: early recognition, avoid becoming part of the problem, isolating the patient from others, and notifying the appropriate supervisor of a potential HazMat situation. Quickly preventing these individuals from entering the medical facility and immediately having them remove their clothing will go a long way towards mitigating the potential for continued exposure to the patient and harm to others. A soap and water showering is the most common method of decontamination performed after clothing removal. It is critical that a safe distance between the patient and caregiver be maintained, and all responding personnel should be wearing appropriate personal protective equipment. There are several reasons for performing decontamination at the hospital. The first is to confine contamination to people and areas already contaminated, rather than spreading it to others or to the inside of the hospital. It is also a key step in patient care because removing toxic substances minimizes the amount and degree of the health effects on the victim. Finally, decontamination of personal protective equipment at the conclusion of an emergency decontamination operation provides assurance against transferring the hazardous substance from the PPE to the person wearing it, to other personnel, or to the hospital. The method of decontamination performed at the hospital varies depending upon the nature and type of release, if decontamination was performed at the scene, availability of resources and personnel, number of victims seeking care, and capability of trained first receivers. In addition, environmental conditions and the ambient temperature, signs and symptoms exhibited by victims, initial toxicology information, and perceived patient needs and desires also influences the type of decontamination provided. When performed, decontamination should occur upwind, uphill, and at enough distance away from the release area to prevent recontamination. Due to the broad and often unpredictable nature of a hazardous material release, a one-size-fits-all approach to decontamination should not be pursued. Rather, a variety of methods should be available and used and scaled accordingly. In general, there are 3 tiers or classes of decontamination available: self-care, gross decontamination, and technical decontamination. These tiers are not required to occur in a stepwise manner, but rather selected and used based on the nature of the incident, patient needs, and available resources. In self-care, victims are able to remove and contain their own clothing without waiting for a formal decontamination process to be set up. In some circumstances, such as a gas or vapor exposure, no additional decontamination will be required. In gross decontamination, the primary objective is to quickly reduce contamination on the clothing, skin, or hair as soon as possible after contamination has occurred. In some circumstances, this can be accomplished prior to clothing removal by spraying the victims from a high-volume, low-pressure water source, such as a mass decontamination shower or handheld sprayer. Both self-care and gross decontamination are aimed at saving a patient's life and reducing any adverse health effects by lowering the level of contaminant in the patient's immediate area. One or both should ideally be accomplished before any life-saving procedure is undertaken. As a result, both procedures are very time-sensitive. In technical decontamination, the objective is to reduce a patient's contamination to a level that is as low as reasonably possible in order to minimize the potential of contaminating others. Typically, this level of decontamination incorporates a formal soap and water showering. Once complete, victims can be evaluated and treated in a normal manner inside the hospital with only standard precautions attire required by staff. Perform decontamination whenever a patient is known or suspected of being contaminated with a hazardous substance. In most cases, the decision to perform decontamination is subjective and commonly made without clear knowledge of the agent, its physical properties, or true evidence of contamination. Performing decontamination is not without risk, since the procedure itself can cause injury, and its use commits the hospital to expend limited resources and material that diverts staff from the care of other emergency department patients. Taking into account the presence or absence of exposure signs and symptoms, visual evidence of contamination, location of the victim relative to the release area, or any available toxicology information can enhance decision objectivity. Having this information at hand also helps Decon team leadership adapt the decontamination method deployed with the risk at hand. Perform hospital decontamination at a pre-designated location with entry and exit points clearly marked and separate flow patterns for patients and personnel in order to limit the spread of contamination. The location where decontamination is performed should ideally be located near the emergency department, but away from the normal patient traffic flow of the hospital. The designated decon area should have access to the decontamination equipment, respiratory gear, chemical protective clothing, and support supplies. In addition, the decon area should have a source of warm water, electricity, and patient privacy capabilities. This is an ideal location for decontamination and may require some modification to your facility to accommodate this setup. If, however, a fixed or permanent shower facility is used within the hospital, it should have a separate entrance from the outside, an independent negative ventilation system that exhausts air to the outside, and a holding tank to contain water runoff. For all decontamination processes, the patient traffic flow should be designed to keep contaminants as far from the emergency department or air intake units as possible. The choice between using a portable versus fixed decontamination system varies depending upon available resources, ambient weather conditions, and budget constraints. In some circumstances, having access to both types of systems is ideal. When comparing the two types of systems, portable equipment is typically less expensive, often requires minimal storage space, sets up quickly, and is disposable if needed. Portable equipment allows the decon process to occur outside, away from the hospital's normal patient traffic flow, which helps reduce the risk of spreading the contaminant to the inside of the hospital. Setting up an outside decon area affords extra space to triage, evaluate, and treat more victims. Outdoor decon also reduces the level of respiratory protection required, since the open-air environment allows vapors to dissipate safely, thereby reducing the inhalation risk to first receivers. When selecting portable equipment, look for a system that is quick and easy to assemble with minimal manpower requirements, offers adequate privacy, is stable in moderate wind conditions, and is durable enough to be reused over and over. Performing decontamination inside a fixed facility reduces adverse weather exposure and provides a means to enhance patient privacy. If used only for decontamination and not for storage, these rooms are quick to set up, preventing any unnecessary treatment delays. Because of inherent space limitations, fewer victims can be cared for simultaneously. At a minimum, the room should be large enough for 2 victims and 2 operations team members. These facilities should be engineered with an independent ventilation system from the hospital, have separate entrance and exit points, a method of water collection, and quick access to utilities. Since decon rooms may be considered a confined space environment, if not engineered properly, a higher level of respiratory protection may be required. Portable shelters, in many respects, are a hybrid between portable and permanent decon systems. They offer necessary privacy and weather protection and are typically multifunctional. Many are pre-plumbed to readily provide showering capability. The setup of the shelter should be intuitive and quick, so personnel are willing to use it not only for multiple casualty events, but also for those incidents producing only a few victims. An objective endpoint for determining when an individual's decontamination is complete is not readily available. Relying on the presence or absence of exposure symptoms is not reliable, since human senses can still detect the presence of various agents even though their actual skin concentration is well below harmful levels. So how long should a victim shower to be considered truly clean? Experts recommend showering intervals between 30 seconds and 5 minutes, depending upon the agent and the water temperature, pressure, and volume used. Insoluble chemicals such as petroleum products require longer washing as compared to soluble agents such as ammonia and chlorine that virtually disappear within the first few minutes of decontamination. In many hospital systems, decontamination is considered complete when a thorough 3 to 5 minute head-to-toe showering has been accomplished. Practice training with a simulated contaminant such as syrup to help ensure your process of decontamination is thorough. In multiple casualty incidents, patients should be sequenced through the decontamination system in the fastest and most efficient manner possible. This philosophy should be supported in advance with a decon corridor configured for ambulatory, semi-ambulatory, and non-ambulatory casualties. Ambulatory victims can remove and contain their own clothing and proceed through the decontamination process with simple verbal coaching, even before the decon team has dressed in protective gear. Once the decon team is readied, the decontamination of those victims with the highest level of contamination or acuity should be addressed. The principles of decontamination, including clothing removal, shower if needed, and treatment, remain the same regardless of the victim's age. Children, however, do pose unique challenges that must be addressed in the decontamination process. Children develop significant anxiety and may become inconsolable when separated from their caregiver. Their thinner skin and rapid respiratory rates increase their potential for injury from liquid and vapor-prone agents. They are more prone to hypothermia, and depending upon their age, may resist decontamination efforts due to peer pressure and modesty issues. Children less than 2 years of age should be managed by their caregiver whenever possible. Placing infants and young toddlers in a laundry basket through the decontamination process reduces the risk of dropping them. Water temperature of the shower should be kept above 98 degrees Fahrenheit to prevent hypothermia. Children 2 to 8 years of age should also be disrobed and showered with their caregiver. Privacy remains a larger issue for children between 8 and 18 years of age. Any barrier to effective communication must be considered and addressed in order to enhance the outcome of an emergency decontamination operation and increase victim compliance. Examples of these barriers include language, disability, and culture. Appropriate signage using pictograms to illustrate the various steps in the decontamination process, theatrical-like demonstrations of the activity expected at each decon station, and the strategic positioning of interpreters can improve communications. Recognizing the inherent need for modesty through the use of privacy screens, separate showers for men and women, and gender segregation of staff should also be considered. Wheelchair patients should be allowed to perform their own transfers whenever possible. Proper positioning of occupational and physical therapists may also prove valuable. Having access to steadying devices such as walkers within the hospital decontamination zone may also be helpful for people with mobility issues. For planning and training purposes, it is useful to divide hazardous materials events into two general classes: small-scale releases and large-scale releases. These two classes commonly differ in terms of frequency of their occurrence, the number of patients generated, and the amount of resources required in the response, both on the scene and at the hospital. Small-scale events involving hazardous materials are more common, generate few casualties, and typically receive a response from the local fire department, and may or may not get support from a hazardous materials response team responding from a more distant location. Small-scale events could be caused by emergency spillages or releases, or may be the result of hazardous materials encountered at fires, traffic accidents, and other emergency incidents. Law enforcement may find unknown chemicals leaking or in open containers at illicit labs. Even police use of pepper spray to restrain a combative subject can result in the need for decontamination activities for 1 or 2 people. The ability to receive and treat victims from small-scale releases should be an obtainable goal of most hospitals. In most circumstances, these victims will require a soap and water showering. A greater number of victims can significantly increase the complexity and difficulty of the decon effort. Major incidents involving large-scale releases of hazardous materials in the United States are fortunately infrequent. Large-scale events place significant demands on local fire and hazardous materials response teams and often require resources and support from regional mutual aid agencies. The potential to generate large numbers of casualties is always a concern with the large-scale event. Mass casualty chemical exposures that involve a large number of people are usually from a vapor or aerosol. Chemical dissemination into the atmosphere results in a wide range of concentrations and possible exposures. Usually only a small proportion of the exposed persons receive large doses. Most people receive only mild exposures. Symptoms typically dissipate once the exposed persons are evacuated from the release area and their clothing is removed. However, since reliable exposure estimates may not be available, even people with mild symptoms need a period of observation at the hospital after exposure. This could require significant hospital resources. Unlike releases into the open air, dissemination in enclosed spaces allows the accumulation of high vapor concentrations. In this circumstance, the proportion of people with high exposures is likely to be increased. The most severe vapor exposures occur in enclosed spaces. After a large-scale chemical vapor release with multiple casualties, removal of clothing may be a sufficient initial decontamination effort, especially when resources are limited. Whenever possible, able-bodied victims should remove their own clothing to enable staff to assist symptomatic and non-ambulatory victims who may require a full soap and water showering. Once the clothing has been removed and contained, patients can be safely moved into the hospital or directed to a secondary assessment center for triage, evaluation, and treatment. This quick procedure eliminates the need to shelter ambulatory patients outside awaiting decontamination. For triage purposes, persons contaminated with liquids or solids, as well as those closest to the actual release, typically require clothing removal followed by showering. Large numbers of exposed victims can be decontaminated with clothing removal only as long as privacy and good direction are provided and adequate security measures are taken. In summary, all HazMat situations are not the same, but the hospital's response to contaminated patients should be standardized. All hospitals, at a minimum, should be able to perform decontamination on at least 2 patients. Planning and training should focus on the unique challenges posed by small-scale and large-scale releases. Just remember, the point of decontamination is to protect you, your coworkers, patients, and the hospital.